Hello all. I am Dr. Swarnika, working as a pediatric consultant and a critical care specialist in Bangalore. I'm very glad to be a part of your journey towards being a specialist in the field of your choice through this platform. So the journey of the pediatrician and pediatrics, it begins right from the time where we take our first breath. Let me take you through the same through a clinical scenario. So you are on call, resident or a pediatric consultant, along with a nurse available there. The obstetrician gives you a call that they are taking up a primary mother who is a term gestation for an emergency C-section in view of fetal distress and a non-progressive labor. Now, in this case, the questions which will pop up in your mind are, this is a high risk delivery. Are you actually prepared? What to anticipate in this delivery? How to assess when the baby comes out? What are the interventions which may be required and when to act depending on the clinical condition of the baby? So let me take you through the neonatal resuscitation steps in detail. What exactly is neonatal resuscitation? It is basically the set of interventions to assist the newborns transitioning to life outside the womb. So when the babies are struggling with breathing or circulation, these steps help you to resuscitate the baby and help them in their struggle. The importance of this neonatal resuscitation, basically, if done properly, it does affect the neonatal morbidity and mortality if the steps are not being followed. And the first golden minutes, that's what we call it, it's very critical. If we miss these steps in those first golden minutes, we are going to increase these morbidity and mortality by causing perinatal asphyxia. We should know the statistics regarding the same. Around 10% of all the newborn deliveries, they do require some form of resuscitation at birth. The perinatal asphyxia, it is an important cause of neonatal mortality and morbidity, and it does contribute around 20% of the same, which is a huge percent. The early and effective resuscitation, on the other hand, is crucial to improve these outcomes. So it is the most effective tool to reduce the perinatal asphyxia, and it is a evidence-based practice. The steps, whichever is designed and structured in this neonatal resuscitation program, it's all based on the evidence-based pediatrics. The Indian Academy of Pediatrics and National Neonatology Forum, they are aiming now at one trained NRP personnel at all the deliveries, irrespective of the place and the setup, through IAP, NNF, NRP, FGM program. So it makes mandate for a person to be NRP trained when the delivery is about to happen to prevent this morbidity and mortality. So this is just an overview. I will be taking you through the details of these steps. So when we begin the neonatal resuscitation, or when we are called at the site, we go through certain steps in our head. The first one being being prepared for the birth. So by being prepared, I mean that you have to ask questions regarding the pre-delivery information to your obstetrician. Be in touch with them. Ask whether it's a term gestation, whether there are any other risk factors involved in the delivery or not. Why are they taking up for the section? As in this case, the questions, the clinical scenario which we discussed, this was a primary mother with non-progression of labor, and there was evident fetal distress there. Also, post-delivery, you will have to tell the obstetrician regarding the umbilical cord management, which forms a crucial part of our resuscitation. So if the baby is breathing, they can do the delayed cord clamping, whereas if the baby is not breathing, they have to clamp and cut the cord immediately. Now, further, if the baby is breathing well, you just have to put the baby next to the mother, do the delayed cord clamping, and do the basic steps by wiping out the baby and drying out the baby. If the baby is not breathing, you will have to cut the cord immediately. And again, follow the initial steps by stimulating the baby, drying the baby, and doing the suction for the baby. Further, you may have to consider doing a positive pressure ventilation if the baby still does not respond to your initial steps of stimulation, drying up, and warming the baby. If further no response, you will have to be prepared with the chest compression and advanced airway in case it is required. And at this step, also you will have to call out for help because you are the single person available. Now, after this all resuscitation, if the baby responds, you will have to consider them sending to the nursery or the NICU setup. And if does not respond, then you will have to consider the refractory causes for those unresponsive, uh, the child being unresponsive or refractory hemodynamic instability. So, what are the key to successful resuscitation, anticipation, and preparedness? The assessment, as we discussed, that pre-delivery questions are mandatory to ask. What is the gestational age of the baby? Is it a term gestation or a preterm gestation? If it's a term gestation, the baby will require the basic neonatal steps, including the warmth of the baby and just stimulating the baby by patting at the back and drying up the baby. Whereas if it's a premature baby, you might have to receive the baby at the first itself in a cling wrap or a surface where the temperature is maintained. Whether the baby coming out is having meconium stained amniotic fluid or not. And any additional risk factors, for example, any antenatal scan showing up any abnormality for congenital diaphragmatic hernia or any congenital heart diseases, because all those things are going to affect the post-delivery assessment and management. And at the same time, you have to discuss the umbilical cord management regarding the delayed cord clamping or an early cord clamping based on the risk of the delivery. Now, here you have to prepare your team. If you are not enough member and if it's a high risk delivery, you will have to call for the extra team members and do a proper equipment check. Without doing a proper equipment check, if you are heading towards the delivery, you are inviting a trouble. So you have to, prior to any high risk delivery or even a normal delivery these days, you have to check for the functioning of ambu bag, the availability of proper size ET tube, the functioning of the laryngoscope, whether a functioning suction apparatus is there at the site, a pulse oximeter which is working with the target saturation number for your references has to be put in any delivery room, in any setup. So pods of the small points to remember here as we discuss the delayed cord clamping, which is done for minimum 60 seconds. And how to check the functioning of ambu bag is it has to be self-inflating, it has to be an airtight seal, and it has to make a hissing sound. You have to feel for the air pressure against the palm, and bag should recoil immediately when the pressure is released. If these steps are not there, if the ambu is not showing any of these steps, then you have to consider changing the ambu bag immediately. So the initial steps when the baby is crying and breathing well is routine care. You have to deliver the baby, whether it is a normal delivery or whether it's a C-section, to mother's abdomen, provide the baby skin to skin contact, dry the baby there, remove the wet linen immediately, cover the baby with a warm towel, do a DCC, that is delayed cord clamping, initiate breastfeeding for the baby. And again, make sure that the baby and the mother are in proper skin to skin contact with zero separation. That is the most recent guidelines. You do not separate baby and the mother until and unless warranted so, if the baby is sick. Now, if the baby is not breathing, then you have to take the baby to the warmer after clamping the cord immediately. Here, we do not do any delayed cord clamping. You have to shift the baby to a preheated warmer. A closed warmer does not serve the purpose. It has to be a preheated warmer. Dry and replace the wet linen with another pre-warm towels. So you have to make sure that all these things are ready prior to delivery. You have to have a pre-warm towel there. Stimulate the baby and place the baby in snipping position as we have demonstrated below. Suction the mouth followed by nose. Always remember, because once you suction the nose and it is blocked, there are a lot of secretions in baby's mouth. The baby will not be able to take a breath. So always go in that order. First, suction the mouth followed by the nose. Now, at the time of birth, we do assess the Apgar scoring to have a generalized scoring system, because sometimes the subjective errors can happen. So this is a universally adapted scoring system for the baby to assess the seriousness at the time of birth. So it usually includes appearance, pulse, grimace, activity, respiration, and it is scored at 1 and 5 minutes after birth. It helps determine the need for resuscitation. For example, if the Apgar score is like more 7 to 10, it's normal. 4 to 6 is moderately abnormal. You may have to give some support to the baby in the form of oxygen or CPAP or HFNC, whichever is available. But 0 to 3 is a critical score. Any score lower than 7 should alert the medical practitioner that this baby may need some medical intervention. Now, these are the initial questions when the baby is born, whether the baby is full term or a preterm. Sometimes they just come for emergency delivery where you will not be sure whether the baby is full term or preterm. That's when the examination of the baby helps you to find out whether it's a full term or not. If the baby is crying or not, breathing or not, and does the baby have good muscle tone? A baby with a good muscle tone will definitely flex and extend the hands and legs whenever touched. Now, after initial steps, you have to assess. So we have done the initial steps, followed by if the baby is breathing, that's fine. You just have to continue the skin to skin care with the mother and shift the baby to the mother's side. Whereas if the baby is required some kind of resuscitation initially itself or has not been breathing, you have to go for the further assessment. That is assessing the breathing of the baby and the heart rate. So if the heart rate is more than 100, but baby appears cyanosed, you have to check for saturation. And during that transition from the womb to the normal setup, the outside the womb, we have a preset of saturation, target saturation as shown below. So at 1 minute, it's just adding 5 to the previous number so that by 10 minutes, you have to have a saturation more than 85% in the right limb, preductal saturations preferably, but we check for preductal and postductal both. So at 1 minute, it has to be 60 to 65%, eventually 2, 3, 4, 5, and 10 minutes by adding 5 to the same numbers. Now, if the baby is not maintaining saturation, but otherwise breathing and the heart rate is more than 100, just provide supplemental oxygen or some kind of breathing support in the form of CPAP or HFNC. If the baby is having labored breathing or severe retractions. For example, in the case of TTNB, it may be required. In case of premature having mild RDS, it may be required. So have those equipments available or know where you have to refer in these cases. If the baby is not breathing or is having heart rate less than 100, even when breathing, you will have to provide this baby with positive pressure ventilation using an AMBU unit as described before also, and I'll be taking you through it later. Now here, when the baby is not breathing or gasping or having heart rates less than 100, positive pressure ventilation is the most important step here in resuscitation. Believe it or not, 99% of 8-week babies can be revived if positive pressure ventilation is given in correct manner at the appropriate time. That is given within the first minute. So if your AMBU was not ready, if you were not prepared to do AMBU, or if you do not know how to AMBU, you have lost that first golden minute. So when you are initiating the positive pressure ventilation, we had done a check of the functioning AMBU. We connect with the appropriate size mask, which is size 0 and 1. As you can see here, this is the mask. Here you have to make sure that the seal is attained by covering the bridge of the nose and the chin. It shouldn't fall beyond the chin and it shouldn't cover the eyes. Otherwise, the seal will be gone and you will not be able to get a chest rise. And this is how the second figure shows you how to do a sing and clamp technique to provide a tight seal there. So when you have identified the correct size of the AMBU, you have to place the mask as demonstrated in the picture there, and you have to provide the breath. How to provide the breath? It is basically the physiological respiratory rate of the newborn, that is 40 to 60 per minute. And how do you do that? It is making the baby get that positive pressure once in every 2 to 3 seconds. So what we do is breathe 2, 3, 2 and 3. Again, press the mask. Breathe 2 and 3. So it makes sure that every 2 to 3 seconds, baby is getting a positive breath. Now, what is an effective breath? I might be giving the positive pressure through the AMBU, but there is no improvement. because I have not made sure that whether that breath was effective or not. So in this case, you have to see whether with your positive pressure ventilation, the heart rate is increasing uh, with an adequate chest rise. If adequate chest rise is happening, still your heart rate is not increasing, then you have to look for other causes. But if the adequate chest rise itself is not there, then your positive pressure ventilation is not useful. So make sure that the monitor is connected during all these time, because you will have to monitor the saturation and the heart rate through all these steps. So what to do if you're not having a chest rise with the positive pressure ventilation, or you're not seeing an increase in heart rate? There is something called as corrective action, and we have developed an acronym for that. That is MRSOPA. MRSOPA. So 5 rescue steps breaths we provide, and after that we make a check. MR is mask readjustment. As we discussed, the mask should be covering the oronasal area of the face. It should not go beyond the bridge of the nose, and it should not go below the chin. So MR is mask adjustment. Reposition the head and neck. Your head may be too flexed, or your head may be too extended for the baby, where the trachea doesn't come in the line with airway. So you have to reposition the head and neck by providing a proper sniffing position and putting a shoulder roll below the neck, below the shoulder of the baby. Suction the mouth and the nose. There might be a lot of secretions, especially known with RDS, that is respiratory distress syndrome surfactant deficiency, where too many secretions will be there in the mouth and the nose, and you will not be able to do the see the proper chest rise. So suction the mouth and the nose, open the mouth there. Sometimes the pressure delivered through the mask also will not be sufficient. So you have to give an increased pressure by squeezing the bag harder. And if despite doing all this, you are not seeing a chest rise, then you have to consider an alternate airway. That is the ET tube intubation. And if you are providing a proper positive pressure ventilation, you have to continue doing that for 30 seconds. Now, after positive pressure ventilation, which is an effective one, you have to reassess for breathing and heart rate. If the baby starts breathing well, if the heart rates are good, more than 100, you just have to slowly wean off the positive pressure ventilation and titrate the oxygen according to the target SpO2, the saturation, as we discussed in our target table before. If the heart rate is more than 100, but the baby is not breathing well, or the baby is gasping still, you will have to continue the positive pressure ventilation. And if that goes prolonged, then consider intubation there. Now, if the heart rate is less than 100, you have to mandatorily intubate this baby and give the oxygen if the saturation is still below the target. Remember that for the newborn babies, we do not give extra oxygen. The FiO2 during all these steps is still 21 to 30%. Only when we have hemodynamic instability or a situation where heart rates are less than 60, we start giving 100% oxygen to the baby, because that supplemental oxygen itself is harmful there. So just 21 to 30% of the FiO2 is required during all these initial positive pressure ventilation steps. Now, type of care after you have given 30 seconds of positive pressure ventilation, it depends on the duration. So if you were able to achieve the breathing and good heart rates within 30 seconds, you can just shift the baby to the observational care, monitor the baby once in every 15 minutes, and followed by at little more frequent, some frequent intervals, for example, 30 minutes to 1 hour. And if the baby is stable enough for next 6 to 8 hours, consider shifting the baby to the mother side. But if not, then you will have to shift the baby for the post-resuscitation care in the nursery. So this is an overview of what we discussed. Effective PPV includes the heart rates going up more than 100 and seeing the chest rise, and that goes on for 30 seconds. Always do the corrective steps if you are not seeing the chest rise or you are not seeing the improved heart rates. So what are the indications? We briefly discussed before. If there is prolonged positive pressure requirement with bag and mask ventilation, or if the heart rates are still below 100, even after 30 seconds of the positive pressure ventilation, and if you are heading towards the chest compression, you will have to intubate this baby. Sometimes we have an information from the obstetric side that this baby is having congenital diaphragmatic hernia, which is a relative contraindication towards your positive pressure ventilation, and you will have to tube that baby immediately before doing any of the other resuscitation steps. So equipment check, again, for this kind of situation, we have to make sure that we have a blade size of 0 and 1 for preterm and term infant. You have to have a size, ET tube size of 2.5 to 3.5 available there, measuring tapes and adhesives for fixing. And ET tube insertion is usually done with a proper laryngoscope blade under direct visualization. After once you have intubated, again, heart rate more than 100, breathing well. Now this baby has exceeded beyond the positive pressure ventilation of 30 seconds for you. This baby definitely has to go for post resuscitation care. There is no second points about it. Heart rate, if it is between 60 to 100, you should not be shifting at that point of time. Rather, you should continue giving the PPV and wait for the heart rates to become more than 100, because shifting itself is a risk. The transport is a risk, whether it is intra-hospital risk transfer or it's outside and hospital transfer. If heart rate is less than 60, you will have to start the chest compression there. Now, this is regarding the depth of insertion of the tube. It is usually the nasal to tragus length here, plus 1 centimeter. That's how deep your ET tube should go. And once inserted, you should see the mist in the ET tube, and equal air entry should be confirmed by auscultatory method, and the ET tube should be fixed. Now, how to assess your circulation? I kept on talking about the heart rate there. So here, as contrast to the pediatric age group and the adult, where we see the central pulses, you have to assess the heart rate using a stethoscope or even palpate the umbilical cord, because that's included as a central vessel there, and you can see for the pulsations. If heart rate is less than 100, continue ventilation. If it's less than 60, initiate chest compression. Now, chest compression ratio, it has to be in the ratio of 3:1. That is, every 3 compressions, you have to provide a breath. And here we use 2 thumb techniques for intubation. We do not use the whole hand technique here. It's a 2 thumb encircling technique. So this is again, if heart rate is less than 60, after 30 seconds of effective positive pressure ventilation, you will have to connect this baby to 100% oxygen, in contrast to previous steps where we just did 21 to 30% of the FiO2. Now here you will have to call for help, because you will need an IV line or umbilical venous line for the access. So you should have umbilical venous catheter in your unit where you are delivering the baby. In case you don't have, we also use NG tubes to be inserted, and we look for the backflow and then can give the baby medicines through that. You do not waste time in putting the IV cannula in these babies. So here again, you have to continue the chest compression. If the heart rate is more than 60, you can continue with positive pressure ventilation and chest compression for 1 minute. Make sure your chest compression is effective. But if the heart rate is still below 60, you will have to recheck the steps of your cardiac compression. You should see that the chest movement is again happening with your positive pressure ventilation or not. The ET tube is in place. It's happening in a coordinated way. That is 1:3 of every 3 compressions you are providing a breath. And the depth of chest compression, that is 1/3 of anterior posterior distance, and the FiO2 is 100%. So the indication of vascular access is usually the post resuscitation care in the nursery, or providing a chest compression there. What are the medications you may have to use here? This is usually adrenaline. The normal vial of the adrenaline is 1:1000 dilution, whereas here we will require 1:10,000. How to make it? We dilute 1 ml of adrenaline in 10 ml, in 9 ml of normal saline. That gives us this dilution. And out of that, we have to use 0.1 to 0.3 ml per kg per dose. After we have given 1 minute of chest compression and positive pressure ventilation. And if required, if we are continuing with the resuscitation, it has to be given once in every 3 to 5 minutes. Now, suppose if you are having difficulty in accessing the umbilical venous catheter, or you do not have any means to give, you can administer this adrenaline through the ET tube. The dose will be higher. It is 1 ml per kg till the access is established. So you do not delay the administration of epinephrine while doing a neonatal resuscitation. And again, you have to reassess after 60 seconds. If it's more than 60, stop your chest compression. If it's less than 60, continue the chest compression. So this is regarding adrenaline. Sometimes the obstetrician might have told you that this is a child who is having blood loss or who was delivered because of the abruptio placenta. In this case, you will have to give the baby 10 ml per kg of normal saline bolus over 5 to 10 minutes. And if that is not the case and somebody else has had to give the positive pressure ventilation and the chest rise is also not happening, in that case, you will have to do you will have to suspect basically a pneumothorax there, do the chest transillumination test because that's an emergency and you can't wait till the X-ray arrives at your place. If that is positive, then just place the intercostal drain using a three-way stop technique and syringe. This is beyond the discussion of this. Maybe some time we can discuss that also. If there is no response to adrenaline, this is the thing you have to consider. Now, apart from this, sometimes the mother may have received some opioid during her sickness or near delivery period. In that case, every delivery unit should have naloxone handy because that will cause respiratory depression and that might be the cause for the baby being flaccid or not breathing well there. Now, if you are continuing your resuscitation with heart rate of 0 even after 20 minutes of life, you have to consider stopping the resuscitation there because the prognosis is bad and where there are very minimal chances of getting that baby back. And in this case, you should always prime the parents up and post-resuscitation debriefing should be done there. So this we have discussed, the volume expanders using normal saline, naloxone for opioid-induced respiratory depression. This sometimes may happen even during the just immediate steps of deliveries, during the anesthesia, giving anesthesia and stuff like that. So naloxone will become a lifesaver there. So apart from those abruptio placenta or pneumothorax, you should always consider the anatomical defects like CDH, lung hypoplasia, severe PPHN, that may be the cause, or any cyanotic congenital heart disease. This might be the cause of baby not having improved saturations, or you going for an early intubation, or baby having cyanosis. Sometimes even the neuromuscular disorders may present like that, where the corrective steps will be different. You have to consider positive pressure ventilation for a prolonged period. When there is a mass in the lower jaw, this will require a pediatric surgeon in the field, and the tracheostomy will be required, or an advanced airway in a different manner may be required. If severe obstruction is suspected, then there is something called as ex utero intrapartum therapy and tracheostomy, where the baby is partially delivered and they perform the alternate airway technique there and do the tracheostomy immediately. So some special considerations would be the premature infants because they need the cling wrap or the warmer immediately. You cannot afford them losing their temperature or there, because that would be causing them hypoxia and eventually the cardiac compression. Require more gentler handling there because they are very small, teeny tiny babies. They can't tolerate the pressure if just handled roughly. Maintain warmth, and you will have to consider early surfactant in these situations. So your unit should be having the surfactant in this case, or you should know if you are a referral place where to refer these kids out. Now, infant with congenital anomalies, we discussed like congenital diaphragmatic hernia. They will need some specialized resuscitation protocols, or having severe upper airway obstruction there. So this illustrates the importance of a pre-delivery planning there. So you should anticipate and you should be able to deal with the critical situations. You should have help around when you are doing the NRP. Every delivery is a high-risk delivery until unless you see a baby who's breathing well, has good color, has good tone, and has the saturations as expected. So this is an overview of what all we discussed. As we discussed, this is the golden minutes post resuscitation. So first 30 seconds, you are taking a call whether you have to give the positive pressure ventilation or not. Next 30 seconds to 1 minute. Next 1 minute, you have to make sure that the heart rates are more than 100 and that the baby, if requires chest compression, is done in a timely manner. If required, shift this baby to the post resuscitation care. Thanks a lot.
Doctor, by any chance, have you prepared 3 MCQs to discuss?
In this, no. I
It's okay.
thought
It's
this is
okay.
an LS.
No, 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 no.
Yeah,
It's
yeah.
okay. So just